Hello, this is Kenneth Banting, one of the physical therapists in NorCal. I am with Dr. Ko here, one of the ortho specialists. Today we're going to be covering stability and instability of the load-bearing spine. Next slide.
Okay, just a second here. There we go.
To cover this, our goal today is going to be covering a few facts and information about the spine, understanding some of the anatomy, understanding a little bit about what stability means for the spine, what instability means, how we can affect that with range, strength, some of the nervous system, and then I'll be covering a couple of case studies in order to just give a little bit of perspective to that. Next slide. Thank you. So a few things to know in terms of facts. Low back pain is a socioeconomic strain. More than $100 billion is being spent in the US alone. And it's a big chunk of change. Now, 80% of people in their lifetime will experience an episode of low back pain at some point. And according to the Global Burden of Disease in 2010, low back pain is a leading cause of disability. With disability in itself that affects people's livelihood, affects people's families. So there's a lot of chain of events that can be associated with that. Now, majority of back pain is mechanical. They respond positively to mechanical treatments, and that's what OrthoNorCal is able to intervene with. Because in physical therapy, surgical, non-surgical cases, different interventions can be addressed to improve people's low back pain. All right, so next 3 slides are going to be covering some of the anatomy. Just to recap, vertebral spine in our back have 26 total bones, 7 cervical, 12 in the thoracic, 5 in the lumbar region. Then we have the sacrum and the coccyx. As you can tell, there's an S-shaped curve there. That S curve kind of represents a little bit of ability to disperse forces and better distribute them. As you can also see, each of that segment is slowly getting bigger as it gets lower. That is also representative of how much load it can withstand by segment by segment. Go ahead and next slide. Great. So next part just shows you a little bit of an overview. Superficial, so outside kind of palpable tissues, and then a little bit more intermediate level of tissues of muscle, and then deeper. Some people might be familiar with the trapezius, some of the lats, but there are some smaller fibers there in the middle and deeper into the spine. Each of them have a lot of different functions, but as you can understand, they help move the spine better. Now, some of the things that people should understand, it's not that your muscles turn on and then they grab and then they move you. It's not just that. They work in a gradient. It means that if you're extending your back or moving forward, it's not like something is 100% and then another muscle is 0%. It's more of a gradient. Some muscles turn on about 80% and maybe another muscle will turn on about 20%. All of that motor control and that function is kind of distributed in order to have a soft and fluid motion through the movement. Go to the next slide. All right, now the ligaments of the spine. I want people to understand that ligaments connect bone to bone. Really, they're unlike muscles because they don't produce work or effort to move a segment. Rather, they stop tissues or bones from moving excessively. Not much different from a guy wire for a bridge. And they can hold things up. And here you can just see different and get a little bit of an appreciation for all the different fibers of the ligaments throughout our spine. They don't contract, and so they can't really produce force, unlike our muscles. Go ahead and next slide. All right, so spinal stability subsystems. Now, we just kind of reviewed really quickly some of the anatomy and get a better understanding of why that is efficient to understand kind of the whole picture. What we covered is basically the passive subsystems, the ligaments and the bones, and the active subsystems are the muscles and the tendons. What we have yet to really dive a little bit more, it's the central nervous system, and that's the control unit. What I want to cover a little bit about the passive subsystems, which is the structure, the bone, the ligaments, the discs. They don't only just maintain the structure, they also transduce. What does transduce mean? Essentially, from your spine, they pick up some signal, They send that to your brain, and then they send that information back to your muscles to control the movement. That's what's transducing mean. And those signals are picked up by what we call mechanoreceptors, just for some of the nerds out there. Now, it's very helpful to understand that, because those active subsystems, they're not always something that you're in control of. A lot of times this is done in the background. You don't think about which muscle to turn on. These are performed with or without volition or without conscious effort. And why this is important to understand is because any disruption to the passive subsystem, active, or the central nervous system can affect the whole chain. It can affect how your body turns on the muscle. It can affect how your stability in the passive subsystem really is able to engage. Or, for example, a radiculopathy, some of you might have heard of it, like a disc pinching a nerve in the central nervous system. It can affect both how stable it feels and how the muscles engage, too much or too little. Go ahead, next slide. All right, so let's just define clinical stability a little bit more. Smarter folks than I am defines it as spine's ability under physiologic loads to limit patterns of displacement in order not to damage or irritate the spinal cord and nervets, and to prevent incapacitating deformity or pain by structural changes. A lot of words. Essentially, that means that the stability of your spine is there in order to support the spinal cord and prevent discomfort or pain. Now, I like this following definition a little bit better from American Academy of Orthopedic Surgeons. They define clinical stability of the spine as the capacity of the vertebra to remain cohesive and to preserve the normal displacements in all physiological body movements. The most key factor there, I think, is the physiological body movements, in my opinion. You don't maintain stability just in a static position. No one is built just to stand still or sit still for the rest of their life. So you have to maintain stability throughout the movement. When you pick something up, when you grab a child and lift them up, when you're sitting down and standing up, getting out of your car, all of those movements are incorporated, and you still maintain stability in order for your spinal cord to still do what it's supposed to do, which is send signal to the rest of your body. Go ahead, next slide. All right, the instability, a loss of the ability of the spine under physiologic loads to maintain its patterns of displacement. So there's no initial or additional neurologic deficit, no major deformity, and no incapacitating pain. A lot of words again, but I like the lower definition. So loss of stiffness leading to abnormal and increased movement in the motion segments. So if you could take a look a little bit on this diagram on the left side. As you can see, an unstable equilibrium is like a ball on top of a hill. If you move that ball past the hill at the peak, it'll roll down. It'll move on, and it's tough for that ball to stay up there. But if it's balanced up there, it doesn't need much effort. It's stable. But it is unstable because the moment it moves past a certain range, it actually is tough for it to get back. It takes effort to get back to where it's comfortable to sit and stay balanced. Stable equilibrium is on the ball where that pocket is on the hill. Even though it moves away from the range, it can still fall back into the center. So if you can picture your spine as each segment is like a ball in a certain position. The stronger your muscles are, the more control you have with your tissues and your bodies, and the more you have discovered your range, you're more closer to a stable equilibrium. That means that even if you are outside of your range, you're more likely to be able to return to a stable position, so it's more comfortable for your body, rather than falling out of that range where it's no longer controlled. So there's traumatic and degenerative issues such as like car accidents that can throw off people's stability, degenerative such as things that are breaking down that discs over time, and so that affects their stability. And it's also good to understand there's functional instability and mechanical instability. Essentially, what that's defined is that with functional instability, it's when the body is moving past its control. And then with mechanical stability, it's more of that structure that's moving past its control. So if a full shift of the spine versus the muscle is moving that spine over and bending over to reach down. All right, let's go on the next slide. Great, so here, let's just cover what is within what what is our control with all of the stability and stability of the spine. So we have range. First, let's discuss the three main ranges. Excuse me. The three main ranges of the spine is side bending, so going side to side. There's rotation, flexion, and extension, all of which is controlled by different muscle groups. It's important to know that it's good to move the spine. You know, it's not just meant to be bare, and it's not meant to just be staying in one position. A lot of people say, well, I'm not staying in my posture very well, or I need to maintain a perfect posture the whole time. In my opinion, there's no perfect posture. Perfect posture is being able to stay in multiple positions comfortably with no discomfort, and changing that position frequently, because we're just not meant evolutionarily to be staying in one position. Here's a nice photo of my back. Let's go back one slide.
Oh, hang on a second.
No worries. It's a nice photo of my back on a good day. But essentially, all these muscles are just nice highlights of what we can be in control of for our back. And then that's on the right side, it's just a kind of a demonstration how these nerves are exiting some out of the spine and going into different muscle groups. Next slide. Great. So I wanted to discuss a case study. This is actually Dr. Cole's patient. He's a 53-year-old male, and he had an anterior lumbar interbody fusion from L5 and S1. So lumbar 5, the fifth lumbar vertebral segment, and then the sacrum, which is the top part of that base of the spine. And so after this, before he had this procedure, he attended just physical therapy, and that was helpful for some time, but it wasn't enough to fully relieve his discomfort. He wanted to get back to training for marathons and running, and he did complete 26 physical therapy visits. Now, I'll walk through a couple different ways that we built him back up. So his phases of rehab was dependent a lot on healing time of the fusion, because that needs to be pretty well and controlled, and it's no longer going to disrupt the surgery after when we're doing this, all the different phases of rehab. We had to slowly introduce range of motion. We literally had to start from just laying on his back and moving just his pelvis. Okay, he can move his pelvis, then let's try to lift his glutes off of the table like a bridge, if some of you might be familiar with that. Then later on, we were able to actually sit down and just do a little bit of flexion, extension of the back, or side bending, and controlling those motions, making sure that those motions are pain-free before attempting any load on top of that. And then later on, when he did have all of his range back, we were slowly introducing strengthening of the muscles. It's pretty hard to isolate some of these muscles, so we were going more for full control and maintaining that core bracing. It's essentially starting with being able to kind of withstand some load through his core and making sure that his back is not causing discomfort. And then being able to maintain that core brace and maintaining that core brace through sitting or standing. And once he can complete that well, we were able to attempt reaching down, picking even just a pen off of the ground and trying to see if he can maintain his core brace. Once all of that had been developed pretty well, now the later phases kind of forced more into tolerating loading through his spine, because it's meant to be loaded. And so axial means just top-down approach of load, bearing weight through that. And we'd strengthen his lower extremities, making sure that he can withstand his load. And then over time, attempted some impact and return to running. Essentially, that's agility drills, being able to control those step patterns, separating right to left, and making sure that his impact and load is not too heavy. We actually had to look at his running mechanics to make sure he's not bouncing up and down too much, so that there's not too much load for where the fusion was. Right now, he's running up to 10 miles. He's actually signed up for a marathon in December. We're planning to do that together. And he's been overall pain-free from his surgery. And the next case study is also Dr. Koh's former patient. He's a 24-year-old male. He's essentially had a lifting injury. Aside from his back having a pretty big cramp, he had an L4, L5 disc protrusion. The disc was seeping out and pressing right onto the nerve. That nerve controls all of his lower extremity on the right side. And so he's having pain and tightness and discomfort on the right side of his body, on his lower extremity. He wanted to get back to lifting and physical activity. He's a young gentleman. Now, he was more looking for conservative methods. And Dr. Malumphy actually was the one who provided the epidural shot to him. And this quite a bit resolved his pain. Now, with that enough, is resolving his pain going to be enough to return him back to physical activity? Now, to discuss that well, earlier we looked at the three subsystems. We looked at neural, structural, so active and passive. Now, he had an injury to and a neural structure, which is the disc, and that affected how much he can control his low back, caused him some discomfort and pain. And now that discomfort and pain has gone down, but then his active subsystems are not able to function very well. So we had to actually work on his muscle groups and address the ones that are causing too much ness, muscle guarding, decrease some of that, promote a lot of stretches on the tissues that are too tight, and then gradually engage the right musculature, because his body has learned a lot of compensatory patterns to decrease some of this pain. And so your body tends not to be actually optimal. It tends to be very functional, and it's very smart. It's going to smart you. And so it's going to move for you in a way that will avoid pain, but that's not necessarily appropriate to complete the task that people most people do, like pick things up or physical activity. So he completed 17 PT visits total, and we focused on just what I mentioned, decreasing some of his symptoms down his leg, addressing his muscle guarding, learning how to relax certain tissues while turning on the right musculature, and then engaging that core, just like I mentioned earlier. For him, I focused a lot on, some people might be familiar with Superman's, laying down flat on their stomach and then lifting up their head, their upper back, and their legs in order to grab onto that extensors in the low back without causing muscle guarding and muscle strain. His rehab phases focused on maintaining his core stability, so bearing load through his back without discomfort, like deadlifting mechanics, and being able to maintain that control without necessarily breaking that bend in his back and causing his low back action again. And so he had good range, able to maintain his stability, both static and dynamic. So that means lifting something or having load, not just without moving, but also moving around. He currently is regularly weightlifting again, and he's back to tolerating deadlifting and squatting. That's my cases, and I'll pass the mic to Dr. Ko.
I think Leah needs to make some announcements. Leah, did you have something you want to say here?
Yes.
before I
Hello,
get
everyone. Thank you so much, Ken. Thank you for a great presentation. Hello, everyone, and welcome to OrthoNorCal Educational Webinar Series. My name is Leah Rutinov. I'll be the moderator for today's webinar. And just a quick announcement, we will have the webinar recorded and available on our website starting tomorrow, and also a Q&A session after Dr. Ko's presentation. So get your questions ready and direct those to us by using the chat or Q&A buttons on the bottom of your screen. And Dr. Ko, take it away. We'll look forward to those questions.
Oh, great. Thanks, Ken, for using two of my patients as case examples. Very educational session. I'm certainly a big believer in core strengthening and stabilization of your spine using your own muscles. I practice what I preach. I do my core exercises daily for my spinal issues. So I'm going to discuss spinal instability from the surgeon's perspective and what it means when you have an unstable spine that cannot be controlled with what you learn in physical therapy and what you practice daily. I want to say this: core exercises, to use a Latin phrase, and core strengthening or having core strength is a sine qua non to spine health. You must have it. It means it is without it. Literally, it's a Latin phrase. It means without which you do not have it, or without which there is none. But it's not always enough. And that's where I come in as a surgeon. When the core strengthening is not enough, that your therapy has not been enough, that you need a little extra boost, like in Ken's first example, to kind of bring you along to spinal health. I want to talk a little bit about the history of spinal stabilization in terms of the instrumentations and the techniques that we've used. We've come a long way in a century, and even a long way in the last decade or so. And I'm going to discuss a little bit about modern spinal surgical reconstruction. So I'm going to use a patient case example. This is a healthy 42-year-old woman with chronic 10 years of back pain with a 1-year history of pain in both lower extremities, refractory to non-surgical treatment. She got temporary relief with the bilateral targeted epidural steroid injections. She was seen 6 years ago and then responded well to physical therapy at that time. But over time, her pathology just simply could not overcome this. So if you look at this slide, what you see here is something called spondylolisthesis. Now, can you guys see my pointer? You see the mouse pointer or not?
Yes.
Okay, so this slippage of the spine is where that vertebra slipped forward. Well, why does that occur? In this particular case, this isn't necessarily trauma, although it could have been, but there's a break, a defect. That little black spot right there is a defect in the pars interarticularis. We call that spondylolysis or a pars defect. It leads to this spondylolisthesis, which is slippage of the spine. And because of this instability, at this point in time, when this x-ray was taken, she could do well with her core strengthening muscles and do very well. But because of this chronic mild to moderate instability that was only partially controlled, or at least symptomatically controlled with her exercises, she eventually just totally wore out that disc and slipped even more. And you can see that pars break is there, and that pars area allows the vertebra to hook over. Each vertebra hooks, as you can see. This is L5 hooking. I'm sorry, L4 hooking over L5, and the little facet joint you see right there are hooking on that one vertebra. Well, the hook is incompetent. That leads to this. So you can get the spondylolisthesis either because of this either traumatic or congenital defect there, or simply because you wear out your joints. In those cases, you'll see that at L4-5. So this is her MRI, and you can see, well, it doesn't look as bad on the MRI, but what you're seeing here is that, yes, she's lying down in a scanner. So when she lies down on the scanner, her spine reduces. So this is an unstable spine. And then what you see here on this view right there, these little black dots in that little white are the nerve roots that come off the spinal canal. But at L5S1, they've been totally compressed and crushed. And that's why the source of the leg pain. That's called neuroforaminal stenosis. This is on her left side where her worst leg pain is. This is a cross-sectional view looking up from the head end. So history of surgical stabilization. Well, our only option for stabilization in a century ago was basically to rely on a body cast or a brace, but that was only good as long as that was on. So they would do an effusion, taking bone graft from the pelvis and laying it on the transverse processes you see there, maybe doing a laminectomy to take the pressure off the nerves. And so you had to wait an interminable amount of time, it seems 3-6 months for this to heal. And then once that was healed, then you would have a stable spine. You could remove the cast or brace. Well, Dr. Harrington came up with this really innovative idea, the first really true spinal instrumentation in the 1960s, what's known as the Harrington rod. It was first developed to treat curvature of the spine or scoliosis in polio patients, and then began to be used in what's called idiopathic scoliosis, and then also for fractures and other forms of instability, including the spondylolisthesis that I saw. Then in the early 1980s, Dr. Eduardo Luque invented, he was a spine surgeon who I was fortunate enough to know in the early 1980s, developed these rods and wires. And they couldn't afford some of the other stuff. They had to basically use simple wires they got at the stainless steel wires they got at the hardware store, and stainless steel rods that were relatively inexpensive because they couldn't afford the sophisticated implants. Well, it turns out his technique was so innovative and so useful because you would get segmental stabilization. You could wire at each area. It was an ability to make correction and stabilize the spine and not have to rely on 1 or 2 hooks at the ends of long rods. And then it evolved to multiple rods and hooks that were invented by Doctors Cottrell and Dubussé in France. You can see Spine Surgeons International. And this Cottrell-Dubussé system has evolved into other systems where multiple hooks were used to help stabilize the spine and get good correction of scoliosis and stability for fractures. And then Dr. Steffi developed, in fact, one of our doctors, actually Dr. Murray in our practice, who's a sports medicine doctor, actually worked with Dr. Steffi in the late 1980s and helped him develop the pedicle screws, the screws that actually go from the back of the spine to the front of the spine, and he used plates to put this on to stabilize the spine. This has evolved now into rods and pedicle screws, which is essentially what we still now use. Instead of a plate, the rods and the screws have a better connector, and it results in extreme stability. And in this instant stability you get to the spine allows you to have instant, well, not instant relief, but very quick relief once soft tissue healing is gone. And then we developed spacers and cages. Some of the cages went in from the front initially. They were round cages. Those weren't the greatest idea, but now the spacers are more oblong shaped and more natural shaped. This is the big spacer we put in from the front. This is a more narrow spacer with bone graft in that can be put in from around the nerves, either at the side or right from the back. Then we developed synthetic bone grafts in the early 2000s, so we didn't have to destroy the pelvis getting bone graft to get healing. Spinal navigation that allowed us to see real time where our instruments were going. And now most recently robotics, and I do almost all of my lumbar cases with a spinal robot that basically allows us and tells us once we've done the planning correctly to tell us precisely where the screw needs to go. This is an example of robotic planning. This is a software program we use. Once we get a CT scan, we break the spine into its various component segments. We plan on exactly where the screw is. I can manipulate it. I can pick the size, the shape, even the brand of the screw. I can change the angle a little bit and the length, the tilt of the screw. And then in the operating room, we take this plan and put it on the robot's computer. And then we get intraoperative fluoroscopy because each of these segments will move just a little bit. And then we execute this with the robot arm that's attached to the operating table, telling us exactly and point us exactly where we need to put our hole to put the screws in. This has been revolutionary for my practice, saves the patient as well as the surgical team a lot of radiation. So what are the goals for surgery for instability? You want to eliminate the back and leg pain. You want resolution of any numbness, weakness, or tingling. You want to restore the normal backwards curve of the spine in the low back. You want a happy patient, and you want the fusion that you're doing, this welding of the vertebral body, the unstable segment, to become solid and become stable over time and durable. You want to be able to run the marathon. And you know, that one patient that Ken is seeing is going to be able to run a marathon a little over a year. I've actually had one patient that on her own decided to run a marathon 6 months after the surgery, which was against my advice, but she did great and did very well. You want a low complication rate. You want a rapid and full recovery. So the cages that we use, the mechanical considerations, I like to use cages that have a modulus of elasticity close to bone. Any of you on the talk that are engineers, the modulus elasticity is really a measure of stiffness. And if the stiffness and the hardness of the device is close to bone, there's less chance of it settling into bone or causing issues because it's stiffer. You want to relatively easily see the fusion. As you can see over here, there's bone graft growing through the cage, and I know it's fused. So here are the screws from the back and the rods. In this case, we've also put a plate on the front, a little extra screw there to make sure this is stable. You want maximum rigidity. If we do this from the front and back, as in this particular case, you get maximum rigidity. Now, the biologic considerations, there's this infused bone graft that I like to use. It's an RHBMP2. It's a recombinant protein. It's made synthetically. It's FDA approved for placing in cages and through the front, even through the side. And there's types of surgery we can do where we go in through the side. That allow the body to make bone. Now, one of the problems is sometimes there was overgrowth of the bone if it's put close to nerves. Well, that's really not an issue when it's put in from the front. Now, there was also a study that's very controversial, and some of you may know a Dr. Karaji, who's now mostly retired at Stanford, wrote this paper that there was an association with male infertility, ostensibly as a consequence of this bone graft material kind of leaking around the nerves once that were in the front, but that really hasn't been substantiated by other studies. And so although you may hear that, it's really a non-issue. There's also some reports also by Dr. Karaji of potential increase in cancer rates, but really that hasn't been substantiated. It was more of a scare. So surgery for instability in summary. The surgery can be performed with small incisions. an indirect decompression of the exiting nerve root with spacers. So when you jack up the spine with the spacer, results makes more room for the nerves without having to necessarily drill around the nerves and potentially damage the nerves as a consequence of the surgery. It's minimally invasive procedures. For example, on Monday operated on my neighbor's dad. He's an 85-year-old gentleman who had very severe pain. He was an avid golfer. He couldn't golf. We tried therapy. We tried injections. It just wasn't enough for him. He had the instability. We put the spacers in on and the rods and screws on Monday, both parts of the surgery. It was a 2-part surgery that took about 45 minutes to do for each part. You know, he was sitting up in bed, happy, pain-free on the day of surgery. Probably could have sent him home that day, but we did send him home the next day. He's already doing very well, has less pain than he did even the day before surgery, 2 days out. Some days we will be doing some of these surgeries as an outpatient. In fact, we're doing some of that now. You want to have early, reliable bone healing with modern bone graft materials. You want rapid resumption of light activities within 1 to 2 weeks, and nearly all other activities in 8 to 12 weeks. And, you know, sports, including golf, cycling, running, marathons, things like that. And potentially even collision sports if you're a professional football player within 3 to 6 months. Tiger Woods, you know, had this type of surgery performed by a friend of mine down in Dallas and had done very well. I think he won the Masters until he had that unfortunate car accident that has hurt him. So this surgery can work when what Ken offers is not enough. I thank you, and we are ready for questions.
Thank you, Dr. Ko. Very informative. I do have a couple of questions to start with. Let me see. So we have a question. Is it possible to get more information on example 1? Ken, I think that is addressed to you.
Of which example 1? The case study 1, the first.
The case, I believe it's in regards to.
And they're
case.
asking if they could get more information about it.
More information on example 1.
Sure. Yeah. So this gentleman, initially when they presented, I saw them pretty early on, right immediately after their fusion. And so they had some incisions in the front, and that was a little bit of some of the discomfort that they had with initial core bracing. But that over time did improve pretty well. Their discomfort from the surgery was associated with coughing or sneezing, and we worked on splinting that, meaning pressing like a pillow against their stomach in order to, when they sneeze or when they're bearing down, like defecating, that was a little bit more comfortable. And so physical therapy in the beginning is very different from over time as they're trying to progress into activity. And so initial movements were just maintaining their metabolic activity, their metabolic rate, because this individual was particularly someone who was active regularly, and going from activity to completely no activity is not good for the body. And so we were actually working on some exercises with upper body without disrupting the lower body. And so we were having them do very light band resisted bench presses, or bicep curls without a whole lot of resistance, but more of controlled movement, just so that their muscles can turn on without loading so much of their spine. And then when their spine is healed up, we were able to kind of take care a little bit more with controlling more of that range of motion through cervical, lumbar, and then their lumbar to sacrum, where their fusion was at.
So if I can chime in, can you guys hear me?
Yes.
You hear me?
Mm-hmm.
Yeah. So from the surgical perspective, I think the surgery that patient had, although different from mine example, was similar and maybe exactly identical to the one that I showed in my presentation. And Ken touched on an interesting point. I mean, we do go from the front for some of these surgeries. In this case, it's very easy to go between the blood vessels at that lowest level. we actually can move what's called the peritoneum, the gut sac, to the side, still inside the belly. I've had some patients conjure that we actually take the bowels out and put them on the back table while we're doing the surgery, and put them back in. That's absolutely positively not true. There's enough room in there to move them over a little bit to the side and gain access to where we need to go to do the surgery. And the incisions we make, and this is important, they're muscle splitting incisions. We do not cut muscle. We cut the tissue that connects the muscle, but we do not cut the muscles when we do this. And that's one of the most important things about modern spine surgery, that it's minimally disruptive and disruptive. And so early on, these patients will have a little bit of pain when they engage the core, because there's still some fresh healing areas where the incision sites are, where the bands of muscles connect to each other. And so that's the important to have the guided therapy. I generally put the patients through a little bit of water therapy if they're more deconditioned, then move on to the core strengthening under the guidance of Ken and his associates.
Thank you, Dr. Ko. Next question. Does an annular fissure at L4-5 ever heal after the jelly has been absorbed?
Is that for me or Ken?
That's for you.
I'll take that question.
Yes.
So annular fissures, okay, first of all, an annular fissure is kind of like a wrinkle in the skin in many ways. An annular fissure by itself goes along with degeneration, the aging of the spine. By itself, as an MRI finding, without the context of what's going on with the rest of the spine, it has very little meaning per se. And I have many patients that get frightened about annular tears or annular fissures or disc bulges. All of these findings are seen ubiquitously in everybody as we get older. The question is it a source of symptoms or not? But to answer the question directly, yes, annular fissures can heal. Over time, though, I think they probably don't heal and you get more of them, but it's like the wrinkles in your skin. The key is to have a strong core to keep that fissure from widening and having the nucleus herniate out and develop a radiculopathy where you have pressure on the nerves, or an instability where you end up needing to have a more involved surgical procedure. The key is not to focus on that anatomic finding. The key is to protect your back and if you will, deal with aging gracefully. Now the key, and Ken said something very important early in his presentation. In first world countries like the US, 80% of us, maybe even more, will have disabling spine pain at least once in our lives. To it, everybody, you will have it. Take care of your backs, all right? Take care of yourself, get your weight off, keep your core strong, take whatever you need as an anti-inflammatory or a non-narcotic analgesic to deal with it. Do the best you can. Get your epidurals. If it's necessary, you have spinal instability that can't be taken care of, or an intractable nerve pain, you may need surgery or injections to deal with it. But it is ubiquitous. We all will have it. And I have it. I'm sure Ken's probably had it before, even though we haven't talked about it. But we will all have disabling spine pain. It's part of life. We walk on two legs.
Thank you, Dr. Ko. Next question. Do the screws loosen over time, and are update or replacement surgeries needed later in time?
Now, that's an excellent question. In general, most of the spinal screws do not loosen over time because the bone fusion becomes solid, and the screws at that point in time, for the shorter fusions, not maybe for the long fusions with scoliosis where the metal has some ongoing load, but for like a 1 or 2 level low lumbar fusion, they can be removed. They're kind of optional. They're not necessary. Most of the time we don't do that, only if the screw is symptomatic or if there's some reason to take them out. Otherwise, for example, every once in a while there's a screw head that's prominent and causing some pain, but that's really the exception, not the rule. If you do have a loose screw, that's a sign that the bone fusion hasn't taken, that the biology did not do its job. Now, in terms of need for revision surgery, one of the issues with lumbar fusion surgery, it's one of the Achilles heel, if you will, is that it does transfer a little stress to the other segments of the spine. Now, I tell my patients that, well, if you have a bad disc and you needed a surgery for a bad disc, and let's say it's a degenerative problem, the same DNA that coded that disc that went bad coded the other discs, and they're going to go bad eventually too. The question is the surgery we do to fix the one problem make it more likely that you're going to have the other problem? Well, and maybe so, maybe not. But are you going to live your life in fear and not have something done now because of what might happen in the future? I think not. In the case of the isthmic spondylolisthesis at L5S1, that's somewhat more likely because that's more of a congenital developmental problem, maybe arguably traumatic in some cases. But the reality is, yes, there are some patients that do need to have additional surgery, but with modern minimally invasive surgery, it's much less of an issue than it used to be to have that additional surgery because the recovery is more rapid.
Thank you, Dr. Ko. I think the next question is for Ken. After the surgery 6 weeks out, what type of core building exercises can be done from home outside of physical therapy?
So it depends, first of all, on the surgery. But if we're talking about the fusion surgery, then outside of physical therapy, a lot of times with physical therapy, we send them home with the baseline of exercises that they need to maintain in order to progress later on. And so it depends what the baseline is per person. If a person is planking 3 minutes at a time before the procedure, they're likely able to engage that core very well. But then if they're someone who had been sedentary prior to and have the surgery, but is generally fit, just not regularly active, their six weeks post-op is going to look a little bit different. And so it definitely depends on individual. And so my colleagues and I try our best to very much individualize the plan of care for each person that we work with. And I think generally all of us, our goal in physical therapy is that they don't need physical therapy. And so as much as possible, we promote the rehabilitation that they are able to withstand and without pain, because our goal is that they are independent with much of their physical activity.
Thank you, Ko. The next question, how many of these surgeries has Dr. Ko done?
Oh my gosh. You're asking me to count the
Lost
number
the
of
count, didn't
orthopedics
you?
I've done. Well, I do several hundred a year. So I've been doing this for 40 years. So probably now I'm well into the thousands. Malcolm Gladwell has this thing about 10,000 hours to become an expert at something. Well, I'm in my 60s now, so I guarantee you I've done more than 10,000 hours of spine surgery. So yeah, I'm pretty comfortable doing this kind of surgery. So it's well within my wheelhouse. I hope that helps.
That's very impressive, Dr. Ko. Next question. What is the typical precautions for exercises and movement early on post-surgery?
So from physical therapy standpoint, it's generally no bending, lifting, and twisting in acute stages when it's still healing, because for fusion, for example, we want to make sure that that is secure, that it heals well with the bone, and the bone accepts that procedure very well. And from Dr. Ko's perspective, if you have something else in mind for that.
So there's two things that I'm looking at from the point of view of restrictions. One is to protect the healing of the soft tissues and bone early on. Early on, it's really more about the soft tissues, disrupting the wound and healing and everything else, having a dehiscence, which is a separation of the surgical incision. In patients that have extraordinarily soft bone, and that's not very often, fortunately, but if the patients have osteoporosis, I'm not really concerned about my rods and screws and cages and plates and everything. I'm concerned about whether or not they will cut through the bone or become loose because the bone is soft. In a young person or even an older person with good bone quality, it's a non-issue. I've had patients have seizures. I've had patients have falls and car accidents early in the postoperative period and not disrupt it. And the patients will always come back. We'll get an x-ray when they've had something unusual happen in the early postoperative period. So with modern surgery, it's not that much of an issue. You do want to protect it, of course. You don't want to take any chances. But the other issue is protecting the adjacent segments. You don't want to herniate a disc or something like that at the level above by exceeding your restrictions too early until Ken's got a chance to get your core strong again. When you get your core strong again, apart from the issues of additional stress on the non-fused levels for reasons we discussed earlier, That's really the issue. So it's two things: the soft tissues and bone healing early and late, and also early to moderately late, protecting the other levels of the spine.
Thank you, Dr. Ko. The next question. I had a compression fracture of L4 December 2019, which has healed. What is the best long-term plan to prevent additional problems and strengthen the spine here?
So I'm seeing this question from this particular patient. It really depends upon the cause of the fracture. When it comes to compression fractures, we put them into two categories. One is a traumatic compression fracture, and the other is a vertebral insufficiency fracture. And I can't tell from the question which of these fractures the patient has sustained. Now, if the patient has had osteoporosis or other bone diseases to make the spine weak, the strategies will be a little bit different than somebody who fell off a roof or something like that, or fell snowboarding. If they had the form, or the latter rather, it was a skiing injury or something like that with healthy bone, it's treated non-operatively. When the fracture heals, and you'll go through the rehabilitation process, similar to what Ken described earlier for spine fusions for this as well. Now, if it's a vertebral insufficiency fracture due to osteoporosis, I am a huge believer in getting that osteoporosis treated. If your primary care doctor will not do that, you'll need to find an endocrinologist or rheumatologist, or in some cases, I've done it myself, to get you on medications for osteoporosis to make sure that you're getting vitamin D, calcium, and everything else to build up your bone, because this is paramount. You're at much higher risk of having osteoporotic compression fractures again if you've had one. And there are treatments and procedures for fractures, but you also have to take the next step of getting the osteoporosis treated if that's the case. I've answered the question from two different perspectives. I hope that helps.
Thank you, Dr. Ko. The next question. With the inactivity, what type of diet should be followed to keep the weight down?
So, sure. I'm not a nutritionist per se, but I'm just going to give that disclaimer. I think that there depends on what that person was eating beforehand. I think it's important to take in mind diet is not like I'm going to make this happen and it's only going to be for 4 weeks. Once that's done, I'm going to go back to my old routine. And if people are trying to lose weight and maintain losing that weight, it's going to be important to consider making those changes gradually and appropriately without drastic changes to the body system. Because if someone just had surgery, it is going to be important for them to not going to have as much appetite right away. And so that's going to take a little bit of time to recover. And so a lot of times in acute care, they won't start right away with hard, solid food. So right after the hospitalization, they'll be able to slowly gain some of their appetite. And with physical activity, that appetite is also going to come back slowly. And so here, when we're training them and building back up with rehabilitation, we'll let them know that they have to cover their macros and making sure that they're eating enough protein to build their strength and their muscle, because that's a building block for muscle. Healthy fats so that their joints are well lubricated and so on. And hydrating well, especially if they're taxing themselves and breaking a sweat every time they're coming in.
So my advice is get your advice from your primary care physician or your internal medicine specialist, not Oprah or anybody else on TV. There are all sorts of fad diets out there. From an engineering perspective, I'm originally trained as an engineer. It's a function of calories burned and calories consumed. And your fat stores calories very, very efficiently. And so you need to find a way to burn those calories. And it's a lifestyle change. You have to make a commitment to do it and make it happen.
Thank you, Dr. Ko. The next question or a comment. I would think that a fusion would lessen the mobility. So surprised to hear that they can still play golf afterwards.
Well, so you have to look at, from an engineering perspective and an anatomical perspective, how much motion are you really using with the planned fusion? in an elderly patient where you have a degenerative condition where there's not much motion anyway, the reason they don't move much is because it hurts. Any micro motion hurts. And so they actually move less. There's actually a study in the cervical spine that came out of the Rothman Institute. And we've had two partners here that have been trained at the Rothman Institute and spent time there that showed for multi-level neck fusions, the motion is either the same or better. And the reason being is because any motion hurts. Now, the reality is, I also use this analogy. Imagine you have a large, like a ship anchor chain, and and the lumbar spine has got 5 vertebrae, so it's connected to the thoracic spine and the sacrum. And then let's say you weld 1 or 2 of those links together, the chain can still move a lot. You're actually, you move through your hips. In fact, many patients are more limited by their hamstring tightness for bending over than anything else. There's patients I've seen probably 2 or 3 patients a day that when I raise their legs up to look what's called a straight leg raise sign, I can't get them past 70 degrees because their hamstrings are tight. It's nothing to do with their back. So there's only, the low back can tolerate a lot. There's a lot of redundancy built into the lumbar spine. And if you fuse 1 or 2 levels or even more, in fact, if you do a complete fusion to the pelvis in a scoliosis patient, which I've done, if they have good hips, they can still touch the floor and bend over if their hamstrings loosen up. So the fusion is not the F word that people like to think it is sometimes. And it actually is a good operation for the right patient when done selectively. And it's still a reliable operation. It's not like you're fusing a hip or a knee or a ball joint. There's very little motion in each segment taken individually.
Yes, from the movement kind of perspective, the lumbar spine doesn't sustain a lot of rotation to begin with. That's more of a job of the thoracic spine. And so when someone wants to golf again, we actually go through that movement and see where that movement is coming from, making sure that they're not irritating their low back and they're getting some of that movement more from the control of their thorax and trunk better, and their hip is rotating with that rather than just their low back.
Thank you for answering the question. Next question, is the fusion and the disc replacement the same?
The short answer is no. But the disc replacement is a fantastic topic. And Leah, maybe we can do a webinar on the topic of disc replacement in the future. But a disc replacement is a way of taking a patient that has a disc that needs to be removed, either because the disc itself is painful or because it's herniated, pushing on the nerves, and then replacing it with something other than a spacer that results in fusion. In the most commonly nowadays in the United States, the disc replacements are done on the cervical spine. The reason being is kind of historic, because the best operation in the neck to take pressure off the spinal cord and spinal nerves is actually to remove the disc, take the pressure off the nerves, and then you got to put something back in. What we used to do, and this was developed by Doctors Robinson and Smith, an orthopedic surgeon and a neurosurgeon at Johns Hopkins in the 50s, and I had the honor of meeting Dr. Robinson, was there in my fellowship in the 1980s. He was still seeing patients. He wasn't operating. He developed that operation. The two of them developed that operation. It's been worldwide used and maybe modified slightly. Now we'll put plates on and we'll use the PEEK cages and everything. But the disc replacement operation was developed in the late 1990s, early 2000s. Dr. Goffin, who's also a friend of mine in Belgium, he actually did the first Bryan disc replacement. Dr. Bryan was a spine surgeon in Seattle, Washington, to develop that, and I was fortunate enough to be on the clinical trial for that. So for nearly two decades, since the early 2000s, I've been doing disc replacements in the cervical spine. It's a great operation. I did it for yesterday in a patient that had pressure on the spinal cord. The disc replacement has also been developed for low back pain. Most of the time, you're treating a painful degenerative discs. The problem is it's a low back pain operation. It's not an instability operation. And even though these discs are FDA approved, they're almost never covered by insurance. They're categorically not covered by Medicare in the low back. And this was actually predicted by my mentor Dr. McAfee about 5 years after they were developed, that it would be more accepted in the cervical spine than the low back, and it turns to be the case. I think it's unfortunate because I think there's a subset of patients that have really bad discs, say central disc herniations. They've got back pain coming from that would benefit from a lumbar disc replacement, but it's really hard to do it. We can get these patients approved by the insurance company for a lumbar fusion, but not a disc replacement. And just so that you know, the mobility that you get restored from disc replacement is not exactly perfectly normal. It mimics a normal activity, but it's not the same as a young, healthy disc. But it is better than, I think, a fusion in selected patients.
Thank you, Dr. Ko. The next question. What are the best ways to support the spine if extreme osteoporosis is caused by an autoimmune disease?
Well, the best way to support the spine, I think, is to go see Ken and get your core strong. And then if it's the structural bone you're worried about, then you need to try to get whatever medical treatment you can get for the osteoporosis. I think that's what's key. Now, generally, if you have an autoimmune disease, it's not, without knowing more details about exactly what it is, most of the time often autoimmune diseases are treated with steroids, and it's the steroids that are inducing the osteoporosis. So that's my perspective on that. So
thank you, Dr.
I hope that
Ko.
helped.
Yes, and then that's all for the questions. We are going to wrap up the webinar. I would like to thank you and Ken for your presentation and your time, and thank everyone who joined us today. The webinar recording will be available on our website tomorrow. You can replay and watch it over. If you have any additional questions, please email us at info@orthonorcal.com or call the office directly at 408-412-8100. With that being said, I wish everyone enjoy the rest of their day, and bye-bye. Till next time.
Thank you. Thank you all.
Thank you very much. Bye-bye.
Bye.